pathway or endothelin vascular pathway. So prostacyclin and prostacyclin analogs are an agonist that causes vasodilation, and NO pathway then again causes nitrous oxide pathway that increase vasodilation. Endothelin receptor antagonist, because the endothelin increase, if there is increase in the endothelin, causes vasoconstriction. So endothelin receptor antagonist. While there is no cure for PH, current pharmacologic therapies will improve morbidity and mortality. Prostaglandins and prostanoids. In the PH, endothelial dysfunctions and platelet activation causes an imbalance of arachidonic acid metabolism. So prostacyclins were used to reduce the level of thromboxane A2 that is responsible for vasoconstriction. And in this prostacyclins, PGI2 activates cyclic adenosine monophosphate cyclic AMP dependent pathway that mediate against vasodilation. Prostaglandin I2 also has anti-proliferative effects in the vascular smooth muscle cells and inhibit the platelet aggregations. So it's a two-way actions. It reduces anti-inflammatories at the site or anti-proliferative activities and vasodilation both. Protein levels of prostacyclin synthesis are decreased in the pulmonary arteries of patients with having a so imbalance of mediators is addressed by the exogenous administration of prostanoids as therapy. Epoprostenol, that was the first prostanoids that was invented in the management of PAH. It delivers as a continuous intravenous infusion, so improves the survivability of PAH. So epoprostenol is a injectable form and used in continuous IV infusion. So an efficacy, if we see efficacy, the WHO FC class 3 and 4 PAH patients were demonstrated in a clinical trial have improved the survivability or quality of life, mean pulmonary arterial pressure, PVR, and 6-minute walk distance and mortality, all these improved. Treprostinil has a longer half-life than epoprostenol, and it allows a subcutaneous along with continuous IV infusion. So we can use treprostinil if we wants to give an intermittent phases. So we can give in a subcutaneous rather than intravenous infusion. Recently developed inhaled prostaglandins like provide the beneficial effects infused prostacyclins without inconvenience and side effects. There is a lot of side effects with using continuous IV infusion in the form of infections and reactions. So inhaled iloprost and treprostinil have been approved by the WHO for FC class 3 and 4. Selexipag, that is oral non-prostanoid diphenhydramine derivatives that binds the prostaglandin IP receptors. That is not prostaglandins but binds with the receptors. That is analogs to the prostaglandins and permits us twice daily dosing, but it also in subcutaneous use of Selexipag. Phosphodiesterase 5 inhibitors like sildenafil that has again increased cyclic GMP that level activates cyclic GMP dependent signaling pathway and causing vasodilation and inhibition of platelet aggregation. So that augment the pulmonary hemodynamics and have a benefit of prostaglandins along with the prostaglandins in the use of PAH. So independently sildenafil is not used in the PAH but along with prostaglandin or the other NO pathway or endothelin receptor inhibitors. Now endothelin receptor antagonist ERAs target ET1, potent endogenous vasoconstriction and vascular smooth muscle cells. Endothelin levels are increased in the cases of pulmonary hypertension in the form of increased PVR and mean pulmonary arterial pressure, and 6-minute walk test distance are decreased, and carbon monoxide level as cardiac output is decreased, and ERAs block the binding of ET1. There is two type of receptors, ET1 and ET2. In ET1 there is a ETA and a B. So ERAs block either ETA or the both. ETA receptor found basically in the pulmonary vasculatures that causes vasoconstrictions. In the normal pulmonary vasculature, ETB receptor are found on endothelial cells and mediate ET1 clearance, that is responsible for the clearance of the ET1A. 3 ERAs are approved: bosentan, macitentan, and that is non-selective, and selective ETA receptor blocker is ambrisentan. So bosentan, that improves the hemodynamics and capacity of exercise, and worsening is delayed because the overall life cycle of survival life of a PAH advanced stage of 3 or 4 is approximately 5 to 7 years. So by which the treatment in the right manner, in the right combination, we increase the life survival of life more than 6 years, up to 10 to 15 years. So that is good. So randomized placebo control phase, third bosentan randomized trial control, breath, compare the bosentan or placebo. That improved, shows that the 6-minute walk test and the WHO classification have improved symptoms. But there is no trials that evaluate if there is a selective ET1 receptor is more beneficial than the non-selective. Then NO pathway. NO is derived from the endothelial cells, as you know, that activate cyclic GMP and generate in the vascular muscle, smooth muscle cells and platelets. That cyclic GMP is a second messenger that induced vasodilation and causes the relaxation of smooth muscle cells, and as well as it inhibits the platelet activation and aggregation. So in this NO pathway, there is a PDE5 inhibitors. So cyclic GMP phosphatase diestrase type 5 inhibitors prolong the vasodilatory effect of NO, especially within the pulmonary vasculatures. There are 2 types of PDE5 inhibitors used in the treatment: there is sildenafil and teladanafil. Both agents have improved hemodynamic and 6-minute walk distance. Riociguatate, that is recently introduced drugs that again have soluble cyclic GMP stimulator that acts synergistically along with NO, that is an endogenously generated NO. So this is also a beneficial. Research has significantly improved exercise capacity in the pulmonary hemodynamics. Recently, there is many trials that have suggested there is a combination therapy is more effective than the isolated or monotherapy. So there is an add-on therapy targeting a different pathway when there is an inadequate clinical response or the clinical deterioration with monotherapy. In the clinical practice, there is a starting off with the monotherapy. If there is a deterioration or there is a inadequate response, then you have to add, that is add-on therapy. But combination therapy has a number of hypothetical advantages, like multiple pathogenic pathways are identified as like the 3 pathways generally. So, and the PAH have again the neoplastic nature. So this approach have increased the benefit, and there is a complex approach that like HIV, cancer, heart failure, we use there is multiple therapies in a single stage. So that is also shows that the retrospective study from the French PAH network reported benefit of the triple combination therapy. So targeting all the 3 pathways. For this, they have reviewed with the bosentan, sildenafil, and intravenous epoprostenol therapy. Patients who have randomized combination of ambrisentan and teladanafil, ambrisentan monotherapy or teladanafil monotherapy. So we resulted out in the form of there is ambrisentan and teladanafil was associated with 50% lower risk of the clinical worsening. That shows that the isolated or monotherapy ambrisentan with or the teladanafil have lower efficacy rather than ambrisentan and teladanafil or sildenafil. So this shows there is a combination therapy is more effective for PAH.